Recording. I think S started recording. Yes. Let's see who else is attending. We'll give it one more minute and then we'll start. Yes.
Yes.
Okay.
Good morning, Gopal.
Morning, hi.
Right. Okay. I think we should make a start while people continue to attend. So, buongiorno, everyone, and welcome to the new MSK Pathway and Safety Training Day. As in every other similar occasion, I must start again with some housekeeping. So, the emergency exit is which each of your emergency exit is. Just remember, toilets are where your toilets are, and during the coffee break, the coffee will be there only if you make it this time. But my coffee will always be better, unless there is any Italian in the audience that wants to enter a competition. I always start with this funny start. Okay, there is a specific mix of attendees today, and these are non-medical referrers and reporters. So mainly physiotherapists and then reporters, which are divided in consultants, registrars, and radiographers. The reason for this mix, for this distribution, is that the new pathway will work only if the level of communication within this very team is high. Uh, uh, Today's training will seem to be only for X-ray of the hips or the knees, but this can be extended to other joints and to other modalities, including MR and ultrasound. But most of all, today's training will make you expert at a new way of reporting if you are a reporter, as well as interpreting the wording of the report if you are a referrer. Now, the CCG, together with the NHS England and all the rest of the band, including NICE Guidance, Royal College of Radiology, etc., they have introduced a new MSK pathway where there are MSK hubs uh, made mainly by physiotherapists, and they act as a sort of a fulcrum of the pathway itself. And it is now for us to make it work by making this very team the best at communicating. So why the CCG has created this new pathway? Because the old pathway is obsolete, because there were a lot of unnecessary requests, as we will see, and because it is very important to streamline the experience of the patients when they come to our attention. But all this can be clearer if I tell you my perception of the difference between the old pathway, which I call the clover, and the new pathway, which I call the tripod. The old pathway was like a clover. Okay, so let's make an example to make it clearer. A GP receives a patient with a knee pain. The first thing that the GP would ask is, when have you had an X-ray or an MRI? No. Okay, let's do it. And the GP tries to treat this pain with paracetamol and ibuprofen, classically, but the pain is still there. So the GP thinks, okay, where do I send you? I send you to the surgeon. Well, the first thing that the surgeon would say is, when have you had your X-ray or MRI done? 4 months ago. Let's do it again. But after the consultation, the surgeon will say, man, you are not surgical. Or man or woman. you are not surgical. I'll send you back to the GP. So the GP is back with this patient in his surgery. And so, you know what? I'll send you to the physiotherapist. Well, the first thing that the physiotherapist will ask, oh, when have you had your X-ray and MRI done? 6 months ago. Let's do it again. 3 cycles of physiotherapy go on, but the GP is still in pain. So you know what? I'll send you back to the GP. And the GP, the first thing that the GP would ask is, when have you had an X-ray and MRI done? 4 months ago. Let's do it again. But because the pain is still there, I'll send you to the sport physician, and the sport physician will ask, when is your X-ray and MRI, when they have been done? 6 months ago. Let's do it again. But the pain is still there. Goes back to the GP, who eventually sends the patient to the magician, who is notoriously very good at making things appear. Of course, this is an exaggeration of what the pathway looks like, but is not so dissimilar from a reality. The new pathway, instead, is a tripod, where the GP is not longer the center of the fulcrum, but is the top, the center of the system, but it's the top of the system. And let's make the same example. The GP receives a patient with a knee pain. And yes, the GP asks for an X-ray. But if the GP fails, well, the treatment fails to make this pain better, the GP would send this patient within the new pathway to the physiotherapist, so to the physio hubs. And the physio hubs will have to decide, according to an X-ray or an MRI, where to send the patient. If the patient is better still in physiotherapy for more physiotherapy, or is better to be sent to a surgeon, or is better to be referred to a sport physician. So as you can see, in this new pathway, the fulcrum is made by the physiotherapy hub and the radiology reporters. It is in this fulcrum that our communication must work incredibly well in order to choose the correct leg of the tripod as much as possible first time. The problem that in order to make this work, we had to invent a way of communicating that was as new as the pathway itself. And the surgeons were the first to come out with a very good idea, with an excellent idea, and it was the cork. It was a radiologically surgical or surgically radiological classification of degenerative changes. The only problem with this is that in order to put all these into practice, all reporters, and we are talking about hundreds of reporters, had to learn to use a few codes. And actually, there are a lot of codes. And they were different for X-ray and for MRI. So understandably, the reaction of the reporter was approximately this one. And that's when we got together, like old good friends, radiologists, radiographers, and surgeons in the same room, and we went straight into a peaceful idea, which was based on simplicity. And we thought, how about if we use the simplest terms that we already use every day in our practice and make them our code of communication? So how about dividing the patients in two main groups? The mild and the moderate/severe group. And we use these as keywords in our radiology reports so that the physiotherapist, by looking at those words in a specific position of the report, will know exactly which leg of the tripod to use for that patient. The problem was obviously how. And that's when sitting together in the same room with the surgeon proved to be extremely helpful, because I had the opportunity to ask the surgeon a crucial question. Do you read our reports? And the answer was yes and no. They read our reports to see if there is any oddity. And by oddity, for example, an intramuscular lipoma. But no, they don't use our classification of osteoarthrosis. They use their own classification of osteoarthrosis. And that's exactly how a surgeon would do. So we commented, if the surgeon does not read our report, what's the point continuing on having that style of report? So I asked the surgeon, what's your classification of osteoarthrosis? do you differentiate moderate from mild and severe? And the surgeon said yes, moderate is actually a turning point because beyond moderate, even if it is severe, the treatment is exactly the same. But if it is mild, the treatment is more conservative most of the time. So I said, tell me, what's your classification? And the surgeon said, okay, in order for me to look at an X-ray and say this is moderate, I want to see subchondral cysts that are more than 6 millimeters. So he was very specific. I want to see osteophytes that are more than 6 millimeters. I want to see a particular kind of joint space narrowing, which is bone on bone narrowing of the joint space. And I want to see subchondral sclerosis on both sides of the joint. So let's say the medial tibiofemoral compartment, that would be sclerosis on the femur, on the femoral condyle, as well on the tibial plateau. Anything less than that is mild. Anything more than that is severe. So you see simplicity. Now, before to show you the very key point of this presentation, which is how a report will have to be written by the reporter and how it will have to be interpreted from the physiotherapist for this system to work, I will show you how the new pathway ideally should look like. This is still the tripod that I showed you before, but now is expanded. And at the top, there is still the GP who receives the patient with the knee pain. And the GP maybe asks for an X-ray and then tries to treat this pain with the tools that are available to the GP: paracetamol, ibuprofen, so painkillers. But the knee pain is still there, and that's when the GP will send the patient to the physiotherapy hub, which is all this part here, this central part. And the physiotherapist will have to divide symptoms in severe symptoms and moderate symptoms. And I'm sure they have tools to do so. No matter how moderate or no matter how severe was the initial symptom, every patient should have an initial physiotherapy. Because if that controls the pain, there is no need for X-ray, there is no need for MRI, there is only need to control to monitor the symptom. The problem starts when a moderate pain after initial physiotherapy is still there. In this case, the patient should follow a sort of conservative pathway where the important part is the BMI. If a moderate symptom persists after physiotherapy and the patient has got a BMI that is less than 28, ideally, the patient should be sent to a joint preservation knee surgeon because most of the time this is the destiny of this patient. If the patient in this pathway, so the moderate pain that persists, if the patient has got a BMI that is 35 or less, will still continue to have physiotherapy because there is some evidence that repeating physiotherapy works. With BMI over 35, the patient will be asked to do something to lose weight because that would be ideal in that situation. Let's go to the other part of the pathway, a severe symptom that is not solved with initial physiotherapy. So the severe pain persists. That is when the physiotherapy hub will have to ask for an X-ray. And the X-ray can already solve the problem, providing that this X-ray shows the moderate or severe osteoarthrosis. This is when communication between the reporter and the physiotherapist is very important. If the X-ray shows a moderate or severe osteoarthrosis, no need for MRI. Patient over 59 with a severe pain that persists after physiotherapy and they have got moderate or severe osteoarthritis on the X-ray will have to be referred to the knee surgeon. That's most of the time the pathway. Most of the time this works. Most of the time this patient will have an operation. Not all the time, but just most of the time. If patients under 59 with the same path, they should be referred to sport physician. But if the X-ray in this case shows a mild osteoarthrosis, that's when the MRI can help, because the MRI is better than the X-ray at showing subchondral cysts that are less than that are more than 6 millimeters, osteophytes that are more than 6 millimeters, etc., etc. Now, if the MRI is contrary to the X-ray shows a moderate or severe osteoarthrosis, then the patient will go back to this pathway. And if the MRI actually confirms that despite the severe symptom, the osteoarthrosis is mild, then the patient will go back to the BMI controlled pathway. I hope this is, I made it clear enough. So now, in order to match the surgical classification of osteoarthrosis, we didn't really invent, but we created a new reporting convention. And if this is applied with religious devotion, it will make the pathway shine, because it will make the communication stronger than ever. Let's see how it works. This should be ideally how the report should be made. There should be a section 1 with any acute finding. There will be a section 2 containing the severity of the degenerative changes in each compartment, a section 3 with any other relevant finding, and then the very key point of this reporting convention, the communication code, conclusion, column, and then here there should be mild or moderate or severe, which represents the worst affected compartment. An example will explain this much better. So if I was Shakespeare and I wanted to do a poem instead of a report, I would report an X-ray exactly in this way. And I would say no acute findings, the section 1. Then I would describe each compartment, medial tibiofemoral compartment with mild osteoarthrosis. I can even explain why. Lateral tibiofemoral compartment, normal appearances, and patellofemoral compartment, moderate osteoarthrosis, and I can explain why. So you can see that in these 3 compartments, the worst affected is the patellofemoral compartment with moderate osteoarthrosis. Remember this, because in the conclusion this will be important. Then any other finding, lucent lesion in the quadriceps muscle compatible with an intramuscular lipoma is very rare, but it can happen. And then the code of communication, conclusion, column, moderate osteoarthrosis of the patellofemoral compartment. So conclusion, column, moderate, so the worst affected compartment. It is in this point that the communication happens. If the reporter uses the conclusion column moderate and the physiotherapist interpret the conclusion column moderate, communication done, then the physiotherapist will know that this is a patient that maybe with severe symptoms or maybe with moderate symptoms, but anyway, let's say that patient had severe symptoms. Now we have a moderate osteoarthrosis on the X-ray. So if the patient is over 59, will be referred to a knee surgeon. If the patient is under 59, will be referred to sport medicine. This doesn't mean that the surgeon will operate or the sport physician will solve the problem, but most of the time this is the case. So we have more chances to do it right first time. In a normal day, when I am a very keen reporter, I would report actually right like that. So the report would be shorter than the previous, but conclusion column moderate is still there. The code of communication is still there. So reporters, please use conclusion column moderate, and physiotherapists, please read conclusion column moderate, because it will tell you where to send the patient in the new pathway. But in a normal day, when I've done a lot of work, my report will look exactly like this. And let's face it, how many times we see an intramuscular lipoma? It's very rare. But conclusion column moderate is still there. So no matter how long is your report, please, reporters, try to use conclusion column moderate. And physiotherapists, try to see that part of the report when you are interpreting the report, because it will tell you where to send the patient in the new pathway. As you can see, there is no conclusion because I wanted you to remain with this notion in your mind. Thank you very much. Is there any question? Hey, was I that clear? Thank you. So let's go ahead with the presentations. Am I on time? Perfectly on time. Amazing. Right. So, ladies and gentlemen, Richard Tucker will now give you an example of a mild osteoarthrosis of the hip. Richard, are you there?
I am here, Mario. Thank you ever so much. I don't know whether I can beat that presentation, to be honest, but I'll try and give it a go.
I think you can beat that. The only thing that you will not be able to do is my accent. That's
Yeah, yeah, hands down, you win there. Right, let me see where I can share my screen, and if all is good, can I just somebody give us a shout out whether you can see my screen?
Yes.
Superb. Right then, I'm going to talk now for the. Ooh, it's all gone wrong. Yeah, we're good. We're good again. Right, I'm going to touch nothing and just click. Okay, so I'm just going to give a quick talk in the next 9 more minutes about mild degenerative changes within the hip. Just going to quickly just reiterate what Mauro has said. Really, is that what radiology are doing, and you know, when we look at grading hips, sometimes it is quite subjective, but we are working collectively as a group to make sure we use the same terminology, we use the same construction in the sentences. So as a referrer and a reader of our reports, there's consistency in the message coming across. The other thing that we do when we do look at our images is obviously we look at any prior images, and that is to make sure that we look to check the previous report and what we're currently going to write, so that, as you well know, degenerative changes, there is no regression, but we have had incidences in the past where somebody has perceived it to be moderate and today they consider it to be mild. So we are working on that point of view. The other thing, for those that do any sort of image analysis, just be mindful of any sort of radiographic issues such as technique, i.e. rotation, which can sometimes skew your thought process, whether you think something switches from a mild to a moderate process. And as I say, we're using these educational programs just to get your feedback to help us shape and improve the future, really. Now, I know Teresa Burton's on the call today. One of the things that we're also looking at is how to effectively get communication back to us. And we've got this portal called the Advice and Guidance Portal. And Teresa, I don't know whether you're able to interject here, whether you want to just say a couple of words here. If not, you've got your
Hi,
presentation later.
can you hear me?
Yep.
Hello, can you hear me? Yeah. So advice and guidance is rolled out now to all practices. So if you have a question, you can put that through advice and guidance, and our reporters will pick it up. It doesn't matter what modality about, what specialty, we can handle it and sort out whatever problem you might have. Okay,
Grand.
thanks, Richard.
Thank you, Teresa. So yeah, do use that advice and guidance portal because it is our new way of communicating to us. And for those that refer in, remember to ask for an x-ray of the pelvis and not just the affected hip, because when we do our image analysis and in our interpretation, we'll obviously split it down the middle and compare one side against the other. So it's far useful for us to have a pelvis x-ray request come straight in. So what is mild? Well, the problem is that the arthritis of the hip can refer to a number of different disorders, which predominantly, and if you read this presentation here, just look at the bottom chapter, the paragraph there. So in the young patient, we're looking at arthritis is always associated or universally associated with an underlying mechanical cause, and that is either due to a result of advanced or accelerated wear and tear, such as Mr. Vardy over there. And we're also looking at other sort of conditions such as femoroacetabular impingement and osteonecrosis, and then some developmental delays or processes going on. In the not so young patient, then it's effectively arthritis, which is deemed as mild, is the result of wear and tear. And that's the common conditions that people develop as they age. So it can occur in any joint, but most often than not, we're looking obviously at the hips and the knees as our predominant areas for osteoarthritis. And the key things to take home from my presentation is, I think what Mario just put up on the slide is the symptoms with mild OA, and that is what we're looking for when we do our image reporting, is we're looking for any sort of subchondral cyst or osteophytes that are less than 6 millimeters in circumference. Joint space narrowing, that could be of a single compartment or unilateral, and we're looking at some sort of subchondral sclerosis, but particularly just one side of the joint line. And that's our definition of mild osteoarthritic degenerative changes. And here's two examples of here, two examples. If you look at the bottom left, then we've got a degree of, well, all three of these symptoms. So we've got some subchondral sclerosis on the acetabular, superior acetabular margin there. We've got joint space narrowing. We haven't actually got any subchondral cysts per se, but they are developing. The image on the left-hand side, we've got some medial migration of the femoral head. So we've got a degree of joint space narrowing, and we've got some subchondral sclerosis. Look at this example here of the pelvis. We split it down the middle and look at each hip separately, and you can quite clearly see there's a notable difference between the left hip and the right hip. The left hip has some articular sclerosis and a degree of joint space narrowing. The right hip is relatively fine. And I brought a schematic picture on the right-hand side here. It doesn't correlate to the one on the left, but it's just to get across the key messages of today's presentation for mild OA, and that is looking for the subtle signs of subchondral cysts within the femoral head or in the acetabulum, and looking at joint space narrowing and the development of osteophytes, and in particular just below the actual femoral head itself. And the picture on the left-hand side with the arrow pointing to it is mild osteoarthritis with a small bone spur. Here's some further examples of mild osteoarthritic degenerative changes. If we look at the top left, which has been labeled as number 2, we've got joint space narrowing on the medial side. If we go just to the right of that picture, we can see some developed osteophytes just below the head and a degree of narrowing. And if we go to the far right side on the bottom right here, we can see some subchondral cysts, some joint space narrowing, articular sclerosis, and this is edging towards the next level of degenerative changes. And if we go back to the one on the bottom left, we can see some mild degenerative changes where we've just got some early joint space narrowing and a degree of articular sclerosis, although it's not much. This is my final slide, and I thought it would be useful to bring two examples. These were both lifted from a paper around osteoarthritis of the hip, and these are the same patients. The image, if we go to the top left, image A and image B is the same patient taken a couple of years apart in this particular case, and you can quite clearly see image A is the normal hip and the normal outline, and image B is where we've got mild degenerative changes because we've got some marginal osteophytes, some joint space narrowing, and some articular sclerosis going on. If you look at the images down at the bottom, both A and B, these are from a patient that was done a year apart with accelerated degenerative changes, and we've got some very large osteophytes starting, subchondral cysts, starting to form, and we've got some osteophytes present as well in conjunction with the typical joint space narrowing, especially of the superior roof of the acetabulum there to the femoral head. So with that, I hope you've got a good insight of what we would now consider as mild. I'm going to hand over to Matthew Hawes, who's going to then talk to you a little bit about the moderate and severe elements of osteoarthritis. So I'm going to just turn my screen off now, if I can work out the magic. Over to Matthew.
So I was just working out how to unmute. Is my thing showing now?
Yes.
Yeah. So just to move on to the moderate and severe side of the hip, again, these are the things that you want to be, that we look for, and the things that make it moderate. So this would be any bone-on-bone appearance, and that could be just one part of the joint or diffusely throughout. Subchondral cysts more than 6 millimeters, osteophytes more than 6 millimeters, or if there is extensive subchondral sclerosis both sides of the joint. So by the time they get to a severe joint, we would classify this as being failed, with some deformity and remodeling present in the pictures, and they might have areas of osteonecrosis or even ankylosis if it's that severe. So let's just move on to the pictures so we can see covered mild. Not sure how well this one transfers through the internet, but it was just quite a good one that showed the things nice and arrowed here. So on this one would meet the classification for moderate, given if we measured this osteophyte, it would be more than 6 millimeters. There's complete loss of joint space in the central portion of the joint. And maybe there's a possible small subchondral cyst just here, but nothing that meets that classification. The next one, this one is also quite pixelated, I think, but it does show that this would still meet moderate, even though the rest of the joint looks relatively okay, because we've completely lost the joint space here. That would still be moderate. These are more diffuse changes with a large osteophyte in the acetabular margin and complete loss of joint space just here. And you've got subchondral sclerosis mainly on the acetabular side. And this example here, you can see that the osteophytes are quite small, but on the medial aspect, you've lost all of the joint space. And I guess this osteophyte on the femoral head might be more than 6 millimeters. So by the time you get into severe, then the changes look like this, and this was quite a good example where you've got asymmetrical changes, and or even if the patient has got a predisposing factor in the sort of DDH or something like that, for them to meet the classification of severe OA, this is the sort of thing you want to be seeing. So the femoral head has been flattened and you have remodeling of the joint here with large subchondral cysts and sclerosis both sides of the joint. This one here shows quite a good example of remodeling with osteonecrosis, and that is where a portion of the femoral head has collapsed and it's been flattened here. And that was the point of that one. Here's another good example, and this is complete remodeling. So this patient might even have the beginnings of ankylosis in their joint, where both sides of the joint have completely flattened, and you've got large osteophytes and all of the subchondral cystic changes, if they have any cartilage left at all. So that's all the pictures from me. Just to cover the classifications again, any bone-on-bone appearance, subchondral cyst more than 6 millimeters, osteophytes more than 6 millimeters, makes it moderate, and to be a severe OA, then you want it to be a failed joint with those features that we've seen. So that is me done.
Thank you very much, Matt. Right, is now the
Okay, I think it's me
Teresa.
now, isn't it?
Teresa, before you start, there is a question for you or for
On
Richard
advice and
in
guidance.
the chat. Yes.
Yeah.
On the chat. So as soon as you finish, just
I
right.
was trying to answer it, Mauro, but
okay.
it's not working. So just to put you clear, advice and guidance is accessed on ERS, the electronic referral system service. So it used to be choose and book, but it's now ERS, and there's an area for advice and guidance on there, you just go on to the NUH radiology section.
Perfect.
So-
Teresa, the podium is yours.
Thank you. Can you see the presentation? Okay.
Yes.
Okay. Right. So mild OA then. This is not the most exciting topic for the knee, but hopefully you'll understand the features of mild OA and the references we make in the report. I'm going to give you a visual mind's eye view as a baseline and going through what mild OA looks like and what we're talking about. And also in terms of the referral, how for you to make the perfect referral and what the next steps mean post-report. So features of mild OA, as Mara has already said, reduction of joint space, less than 6 millimeter osteophyte formation, one-sided subchondral sclerosis and tibial beaking. That's a little osteophyte on the tibial plateau or prominent tibial eminences, and subchondral cysts of less than 6 millimeters. The pain patients experience is often quite not in relation to what we're seeing on the radiograph. They often experience more pain than it looks like they should have from the radiograph. It can be associated with chondrocalcinosis, but at the same time, there's no imminent threat to the articular surfaces. So with mild OA, as Maro said, this is the conservative path. So we're looking for a physiopath therapy plan and pain relief suitable to that particular patient. So this is your baseline. This is the Mary Poppins of knee, practically perfect in every way. Beautiful, beautiful joint spaces. No problem here. Why were they x-rayed, you're asking? Well, they bumped into a fence, so, got away with it. Here we have joint space narrowing. The most common area is the medial femorotibial joint space because that's the major weight-bearing line. And then here we have cortical irregularity and arthrosis beginning at the retropatellar surface in the patellofemoral compartment. Still both mild. We touched on obesity and weight. So this is a lady who is a high at BMI, and you can see that the joint space is reducing here, and they're just starting to be tiny little osteophytes beginning, and there's subchondral sclerosis on this tibial plateau, probably mainly because of the weight rather than degeneration, but it's coming. And then you get a change over a number of years. So here we have pretty good joint space in 2019, but the patient has pain, and you can see that 2 years later, that joint space has reduced somewhat more prominently on the lateral femorotibial side. Here's an example of patellofemoral arthrosis. You can see cortical irregularity at the femoral condyles, which is rubbing on the retropatellar surface, causing them pain. And here are tiny little marginals you can see, but this is the start of further things to come. Quite a prominent tibial eminence as well. More prominent tibial eminences and just a hint of what may be a loose body here. And here is tibial beaking, tibial osteophyte that's projecting into the joint space. This is for Bella, normal. And here we have subchondral sclerosis, which can be somewhat subjective. This is quite deep subchondral sclerosis, and there are osteophytes as well. And here we have more well-established subchondral sclerosis that's flattening it a bit, but still only one-sided. And here a little bit of everything, just to add to the menu, a bit of osteophytes, a bit of subchondral sclerosis and joint space narrowing. So, as far as the referral is concerned, we do need 3 forms of ID. How long the patient's been experiencing pain is useful. Once we get going with the new pathway, how many cycles of physio they've taken. What's their previous history? Have they had trauma, meniscectomy, arthroscopy? What can we expect to see? And be specific about the point of pain, please. If there's been an injury, tell us the mode of injury, because we'll know what to be looking for more specifically. And what is your working diagnosis or clinical question? That's it then. Any questions?
That was a beautiful one, Teresa.
It was
I
a quickie,
enjoyed
wasn't it?
Right.
So I'm stopping sharing.
Okay, thank you. Now, Gassan.
Hello, and okay, I'm just going to try and share the screen.
Yes.
Can you see that? Can you see the display? Okay, perfect. So thanks, Teresa, for the first part of the NEOA talk. So I'm gonna basically, as a bit of repetition, and objective is the same, just talk a bit more about the moderate and severe part of the pathway. And this is the idea, as Mauro mentioned, everyone else, is to try and be efficient in reducing the time and repetitive imaging, and then be ultimately cost effective. So going back in history, in 1957, the first attempt of grading mild, moderate, severe, or grading of osteoarthritis was done by Kellgren and Lawrence, and this is still used actually in most of the amongst most of orthopedic surgeons in the country. And what Kellgren and Lawrence did at the time, they've graded all joints, but for the knee we're talking about today, basically they graded it from grade 1 to 4, and if you look at the grading, these are the original paper pictures, you can see there's lots of subjectivity, and there wasn't actually the same mild, moderate, severe. It was more of a...
You're projecting slideshow.
Can you hear me?
We can hear you. We could just we're just seeing the PowerPoint program rather than the presentation.
Oh, okay. What is happening? Nearly, I wasn't at the end of the presentation. That's good. And try to maybe stop sharing and share again.
It's okay. We are early. No problem.
You okay? With now you can just see the presentation, but not the display.
Not the display. So it's okay if you want to click on each slide on the left side. They will see
what
anyway.
If I do this? Is it any better, or is it?
Yeah.
Is it big enough, or?
It's big enough. Yes.
Okay. So basically, just here is what I was talking about is Kellgren and Lawrence, when they've attempted this. This is the original paper. They talked about, grade 1, when you have doubt about whether normal or just not normal, then you kind of have doubtful narrowing the joint and possible ossified. But these are very subjective, as you can see. And then when you talk about grade 2, you start to have possible narrowing of the joint but definite ossifieds, and grade 3 and grade 4. But grade 4 is when you have deformity of the joint. But you can see a lot of subjectivity. For example, what's moderate ossified, what's large ossified. So it's very subjective. In the literature, there's lots of papers that compared lots of different gradings. So at least there is 6 different gradings of osteoarthritis in the literature. And this, for example, one paper looked at all these grading and in a large portion of knee x-rays and compared them with arthroscopy. And I'm not going to obviously go through all this, but you can tell that there's in different grading, there's so many different variations in the description, lots of subjectivity in grading the osteoarthritis. So what I'm trying to do today on this is to, obviously I'm going to talk about moderate and severe, but the idea is that this is more of a local experience from our orthopedic surgeon. Now, when we did this round of presentation last time, we got away with no question about why is it 6 millimeter, and I think this is basically an arbitrary number. I presume the knee and hip surgeon at some point they will publish a local research and be quite unique for NUH, I presume, because it's quite arbitrary. It's not really in the literature so far. So back to what we're doing now, what we're proposing. So when we talk about moderate osteoarthritis, we, as Matthew mentioned and Teresa, we look at features that are more prominent. So you have subchondral cyst and ossifies more than 6 millimeter. Again, and we have a joint space loss where you have bone-on-bone appearances. And also you start to having the subchondral sclerosis that involving the both sides of the joint compartment. Okay, so this is an example where you have now marked reduction in joint space here, where you see now the bone is actually like almost bone-on-bone appearances. And you see large osteophytes, for example, on the patellofemoral compartment. It's definitely more than 6 millimeter. I don't think there'll be a time of like measuring everything. I don't think I think the idea, I think would be with experience kind of eyeballing it more. So I'll just click that off. Now, when it's severe, you have the same features of moderate, so more than 6 millimeters osteophytes, more 6 millimeters subchondral cyst, etc. But then you start to have disorganization of the joint, start to have bone deformity and erosions, more osteonecrosis and fusion sometimes.
Frozen. You have the same problem.
So, for example, on this case of severe OA, I think you're not mute. So, what we see in severe OA is that we see now here the joint start to become very disorganized and a lots of deformity. So you can see quite large osteophytes on this lateral tibiofemoral compartment, and here is a bit more maybe moderate features, while the lateral compartment is severe. A few examples, just back to this example, for example, you see joint space narrowing. You still don't see bone-on-bone appearances, and you see some osteophytes, perhaps not that big, so that's probably mild. And then when you come to this example, you start now seeing bone-on-bone appearances of the medial tibiofemoral compartment. See larger osteophyte, perhaps more than 6 millimeter here, and this is when, but there's no deformity at this stage, so this probably would be moderate. And then when you start to have a bit of irregularity of the bone, this would, although there's a bit of space here, but on the lateral there isn't, so you kind of start seeing towards more severe. But again, moderate and severe management is similar. And just last slide is basically again to hammer home the idea of the ideal report that Mauro talked about. Is basically talk about acute findings. Obviously, need, like for example, hemarthrosis for occult fracture. Then talk about the different compartments classification, and then any incidental finding you may see, and the conclusion was where you have the most effective, most affected or most severe compartment osteoarthritis. And that's me done.
Ghassan, thank you very much for this academic overview. We are now starting to be aware that academic is sort of your signature.
Well,
yes.
Well, after Teresa's amazing presentation, I have to be the one that does a bit more like a boring
Absolutely. No, it's fantastic. Thank you very much. Yes, the classification is a bit arbitrary, as you say, and I think the project of the surgeons is actually to divulgate this thing, and you never know. Every other classification has been divulgated in the same way, so maybe in the future we will see the Nottingham classification of osteoarthritis and we'll become all famous like rock stars. You never know. Any question?
It might be the Albrizio classification, you know.
It's too difficult. No one will be able to pronounce it. Buongiorno classification is much better. Right. Thank you, everyone. We are 12 minutes ahead. So basically, this is the first part. If you don't have any question, we'll close the first part. And please, can you make yourself a coffee and come back at 10 past 10? Is that okay? Yes? Happy coffee, everyone. I'll stop recording. Can someone remind me to restart? Sorry?
We'll remind you.
Yeah. Remind me to restart recording. See you in 20 minutes.
Thank you. Questions. I just
did yeah.
of the presentations. I'm sorry. So I just saved my questions, just write them all.
Yes, yeah, absolutely,
Okay,
yes.
first of all, when is this actually starting? When is the implementation start date? Do you have
It has already started. It has started after a few emails. So we have officially started through an email start date. Sorry, it was COVID. It was impossible to do otherwise. 20 to 30% of people are already have already started using this new reporting convention. This is the result of an interim audit that we have done. After the first of our training dates, I expect the number of people that are using this convention is already on the rise. And after today, we'll continue to audit it and to see how many people are using it. Of course, this is supposed to improve with time. So even if we get to 50 or 60%, that's fine, because then when we will have a QIE, we will sort of represent all these and we'll make sure that the numbers are still on the rise, on the rise, on the rise. This is something that will not happen all of a sudden, but we have to divulgate the method and we have to wait until everyone gets on board. They will get on board. If they don't get on board, we'll do something to make them be on board.
Yeah, the thing is, obviously, we received numerous requests from the GPs per day for knees and hips X-ray, and obviously they didn't had any physio input before. So I was just wondering if we should be rejecting and saying that it's a new pathway, please follow this pathway, blah blah blah, or when do we set a date so we will start doing that? So
the date is today. So the official, basically the official start date is today, because both the training dates have gone on.
We've been rejecting a lot.
Are you okay? Stop rejecting.
Don't reject anything from a GP yet.
Yeah.
Kath, who's been organising a lot of this, said that the new system will go in place when the GP has alerts on when they're requesting. So until those alerts are in place, we're allowing them to carry on doing their normal work. Hopefully the alerts will come on, it'll suggest going to physio, and our GP numbers will fall and our physio numbers will rise.
Yeah, but there is no clear cut here. There is a bit of fade in and fade out of methods. It's normal because it's a big hospital. There are a lot of people involved, so it's normal to be slow. All right.
The pathway is on, then the physio should not be sending the X-ray unless the symptoms are not controlled.
Yes, that's ideal. Of course, there are some exceptions, and I'm sure everyone will be able to tell us why there is an exception. It's medicine, remember. It's not an exact science, so we will never be perfect with that. But most of the time, yes. Ideally, that is what should happen.
And my last question, because I was a bit confused with the presentation. So do we need all the factors to be considered moderate OA? You know,
only one. One is enough.
Okay.
Only if you find only one subchondral cyst that is more than 6 millimeters,
yeah.
Usually there won't be only one thing. But if you find only one, you can say moderate. This is a fail-safe mechanism. So if you say that is moderate, but then the surgeon thinks this is not good for operation, the surgeon will not operate the patient just because we said it's moderate. There is room for adjustment of the thing. So
some presentations, they're considered mild, but there were, for instance, a subchondral cyst that was way more than 6 millimeters. It was clearly seen. So
I saw that.
We should consider it then moderate, even if there's good preservation of joint space.
That's true, exactly. Well, in the end of the day, we are only trying to send the patient where the patient should ideally be. So we send the patient to the surgeon because most of the time the surgeon will sort the patient out. But it's not of course not all the time sending the patient to the surgeon will work. We only expect this to work most of the time. Again, it's medicine, it's not an exact science. So
Can I also mention something? Because, for
Absolutely.
example, if you see some, there will be some time oddity or something like unusual. We have to just use our common sense, because if we sometimes see what looked like subchondral cyst, which is large, but then everything else look normal, it could be sometimes something else. So sometimes, like ganglion or something. So we have just to use our common sense at times. But for the majority of the cases, it will work. But there will be some, one case, because that's life, isn't it? When you see it, an odd something, then we're obviously all happy to help with troubleshooting this.
Exactly. So it is in the grand scheme that majority of the patients will be streamlined. So the system will work more efficiently.
Okay, perfect. Thank you.
Does that answer your question?
Yep.
In this case, see you at 10:20.